learn the information. I have said, for those of you who have me for more than one class, I always say, don't memorize, you need to understand. And that's the truth. You need to be able to understand it so that you can apply it. Yes, there are some things that you just need to memorize it and create it so that it's always there. But there are other things where memorization isn't sufficient because you really need to be able to pull it, apply it, and live it on a regular basis. So with that said, we're going to do some cases. We have some pediatrics, some young adults, and some older adults. So we have 3 pediatric cases. And our first one is about a little guy that I've seen in the clinic, JD. He was 6 years old at the time that I first saw him, and he had a history of phonological problems. Mom said he was a late talker. He really didn't start with his first true words until he was almost 2, about 22 months of age. He's homeschooled now because he was really having problems in the public school setting with a number of things. He was distracted. Mom felt he was socially isolated, very overwhelmed. He was never happy. So she brought him home. She's noticing problems with reading, phonics, spelling, and comprehension. She said that he's really struggling with blending sounds and figuring out which letters correspond to which sounds. He has seasonal allergies that are worse in the spring. She said he's had several. She really didn't know how many ear infections when he was an infant and a toddler. She says he's very sensitive to loud sounds, and he gets anxious or confused, even with the normal daily hubbub of at home with his siblings and his parents. And that if it gets really, a typical day, he just starts bawling and breaks down because the distractions from the noise are so overwhelming he can't do his schoolwork. There's no family history of hearing problems, and he's never had a hearing test before. So, what are your questions, or what are your concerns, or what are you thinking about this kid?
Maybe like auditory processing?
What are the red flags for you?
The sensitive loud sounds, confused, impossible movements, and then the reading, phonics, spelling, some of like the coding.
Yeah. All right, well, let's see what we found. So, otoscopy showed that there was a lot of scarring on his eardrums. That's consistent with recurrent ear infections. His tympanograms were borderline A shallow versus C, meaning that there was reduced movement and the pressure was almost pathologically negative. So that suggests what? That you have negative ear pressure and reduced eardrum. That's a sign that what's not working. Not me, but eustachian tube function. He has eustachian tube dysfunction issues. Okay, his acoustic reflexes were normal if we were stimulating and measuring in the same ear, but if we were stimulating one and measuring the other, they were elevated. So that tells us the cross pathways are not handling information the way that we would expect. Okay? His OAEs were completely normal. When we did his hearing test, he had a slight loss at 250 and 500 hertz, but everything else was normal, and there was no air bone gap. His speech recognition speech reception thresholds were in agreement with the pure tones, and his word discrimination in quiet was 92%. He still had some articulation errors, and so I kind of made a subjective judgment for that. It may have actually been a little bit better, it may have been a little bit worse. I was trying to give him a benefit of the doubt. But regardless, when I gave him speech recognition tasks with a +5 signal to noise ratio, he dropped down to the 75 to 80% range. Keep in mind, typical hearing, typical functioning individuals, when presented speech materials at a 0 signal to noise ratio, meaning that sound and noise are at the same level, will typically experience less than a 10% drop in their score from quiet. So if he were completely typical, we would expect at worst for his scores to drop down to 82%. And he dropped significantly more than that. Okay? At a +5, where speech was still 5 dB louder. So the fact that even with not a great, but a decent signal to noise ratio, he had a pretty significant drop. So, with that said, now, what do you think is going on? Have you changed your mind? Or do you think Olivia's working hypothesis is bearing out? And if so, why?
I think Olivia's right because the acoustic reflexes in the contralateral condition, because they're
Right, so we've got a pathway issue, that's a criteria.
and then as well as the word discrimination.
What do the OAEs tell us? The normal OAEs tell us what? The discrimination issue isn't because of a cochlear issue, which we can get, so it's not that. Well, why else would we have discrimination issues? It's gotta be something beyond there, so it's really in the pathways. So yes, very good, honing in on that. What else makes you think it's a decoding issue specifically? So far, what evidence do we have that it's decoding?
Well, like you did better in the quiet than you did in the noise.
Right, and that's a hallmark of a decoding issue, that auditory figure ground, that degraded speech issue. Very good, okay. Now, what else would you want to see done with this kid?
Maybe provide like an FM or some kind of.
Okay, well, before we even get to that, what other testing? But yes, you're right, FM would probably be huge for this kid. What other testing? What did Mom describe as some of his issues that he's having that we could assess? I see a question mark in the middle of the page. Phonemic and phonological awareness skills, maybe? I would want to see that. Obviously, I didn't give you every single auditory processing subtest that I did. If I'd done that, it would have given it away completely. He did ultimately present with auditory processing difficulties. If he were in a regular school setting, I definitely would want to see FM because he was in a home situation, and actually the problem that he was having was with the noise level in the home. I recommended musician earplugs for him that filter out noise, but still would allow for like when he was lot of his work was done on the computer. It still allowed him to have that. Mom was not real gung-ho with that. And so we ultimately went with getting him custom custom headphone couplers so that he could, if he was doing work, whether he was on the computer or not, he could put those in and it would drown out the background noise and he could really focus on what he was needing to. And if he wasn't using the computer, they served as nice earplugs for him to drown out the background noise, and that did seem to help. I recommended aerobics for him, and it took him forever. By that I mean over 6 months, but he did finally make it through. And Mom said that his phonemic and phonological awareness skills were improving. They opted not to come for therapy. I did recommend that because he was still having ongoing issues with his articulation, and I really felt like we could work on some additional strategies. But they lived about 45 minutes away or so in Indiana, and Mom just didn't want to make that trip on her. I was supposed to come in the spring for follow-up for repeat testing, but so I don't know what happened long-term. I only know what happened like in the first few months. Okay, good job. So our second case is AM. And AM was born at 30 weeks gestation, so he was 6 weeks early. And he weighed 14 pounds, 10 ounces. So not only was he preterm, but he was low birth weight. Low birth weight is typically any baby under 4 and under 5 pounds is typically what they look for. But definitely low birth weight. He referred on his newborn screening, which was conducted at 48 hours, and again before discharge 10 days later. So he was in the hospital for about 12 days before he was able to go home, which is actually pretty good for a 34-weeker. That's not too bad. But anyway, there's no family history of hearing loss, no known risk factors other than the preterm and low birth weight. Because he referred twice on the screening, he's referred to us for assessment. So what do you think? What are you thinking might be going on here?
And you talked about earlier how sometimes, like, when they're born, like, there's like gunk that could be in their ears. So that could be concerning at first, but the fact that it's 10 days later probably means that there's something more going on.
Okay. I mean, it's not impossible. But yeah, you're right, that's not the most likely cause. What else could it be?
Low birth weight sometimes causes hearing loss in children.
Maybe because they were so early, they didn't fully develop all the odds and ends that go with hearing.
Right, I mean, it is possible that neurologically, not ready to come out of the oven. So yes, there's certainly that, neurodevelopmentally. Anything else you can think of? He could have developed middle ear effusion. I mean, there's no reason to think that he might not have. Can happen. So that would cause conductive loss.
Is that just like when the middle ear bones are?
No, middle ear fluid. Effusion is the fluid. What else? It's really the one that the elephant in the room that we really don't want to think about, but is a distinct possibility. He has hearing loss. There's something has happened and he has hearing loss. So, otoscopy was normal. Tympanometry was normal. Acoustic reflexes were absent. both ipsilateral and contralateral. OAEs are absent, 500 to 8,000 hertz, both ears. We did a sleep-deprived ABR, but it was difficult because he was still fuzzy. But responses seemed to fade, so that we could no longer see a discernible response. There's a pattern of 5 waves that we look for, and the wave 5 is the most persistent, and it's the best predictor of hearing sensitivity. And this wave 5 disappeared around 65 dB for both ears. So, because he wasn't maybe in the necessarily the best state, he was still fuzzy. Usually we try to do sleep-deprived measurements because then they'll sleep. That little clicking sound can be kind of lulling to them and they go to sleep. He didn't. So we went ahead, sent him over to the pediatrician. They gave him sedation. Mom brought him back. We got down to 55 dB for the right ear and 65 for the left ear. So, and it was not conductive. So, what's going on?
So it seems like both the sensory and the one, the sensory
Right, and at this point, it's probably sensory, but we can't say for sure that there's not some neural component to it. But we're not concerned neural like a space-occupying lesion or anything. We'd be thinking more like auditory neuropathy or synchrony. The reason that we can't really say for sure is obviously there's a cochlear component because the OAEs are absent. But what we're using to measure is an electrophysiologic response, which theoretically is what the nerve is doing. Well, is it the nerve not providing a robust response because the cochlea is not working and stimulating it, or is it because so we don't really know for sure? This is one of those cases where we would have to say, at least at this point, it's sensory neural. What severity? It's okay to look at your notes and things. This is your opportunity to do that. And if he's in the 55 to 65 dB range, and I should say we did this to tone bursts, so we could do narrowband tone bursts, and we typically do, I would typically do in the 500 hertz range, the 1000 hertz range, and the 4000 hertz range, so that I kind of have an idea of what their hearing is like, so that I can kind of get a, that configuration of the slope. He was pretty flat. But what severity would you give that? I would say probably moderate. What are we going to do with this kid? What should we do? What's going to be our plan of introduction? Yeah, we actually refer to him to children's for amplification because none of us none of us feels comfortable that we are as competent with infant fittings as are those at the children's where that's primarily one of their main focuses. And they have folks that's all that they do. When you send a child to a specialty clinic like children's, typically they have people who are very very specialized. So they've got people that only work with autism, or they've got people that only work with cochlear implants, or they have people that only do feeding and swallowing or whatever. And they do have audiologists, and all they do is fitting and managing the amplification in the little bitty guys. And so, but then what else should happen?
I just had a question, if that's typical that, if they're referred somewhere that, like, say your clinic, that you would refer them back to a place that was specialty rather than, having them fit at your clinic?
If they're over the age of 4, often.
Yeah.
Okay. That's my cutoff.
Good.
I just don't feel comfortable fitting under the age of 4. And so a lot of people do that. It's not unusual. The other reason why I felt that referring to Children's was a good idea is because of what should happen next. Yeah, and they can become, what's one of the things that the Joint Commission on Infant Hearing said is very important, that we establish a medical home. And because Children's can provide at their clinic, they went to Liberty, which also makes me feel good because I have 2 colleagues that work there that I would trust with my own child. And so I feel really comfortable referring into there. That can become their medical home. They have ENT services available. They have audiological services available. If this turns out to be a progressive hearing loss and this child then becomes a candidate for cochlear implants, guess what? They do that there too. And they have a network of social workers and other specialists that can help get them plugged into early intervention. So this is a case where I felt, even though they came to me for the initial follow-up, I felt it was most appropriate after I did the initial identification that I transferred the care of that patient to someone who really could better manage it rather than having come to me for some things. They could get everything that they needed right there. So, does that make sense why we would do that? All right, so let's talk about Tika. She's 5 years old, going on 33. Significant history of middle ear problems. Dad said he lost count somewhere around the 12th one before she was 2. So pretty much she constantly has fluid. She also gets strep throat a couple times per year. She's a mouth breather and she snores loudly. She sounds very hyponasal most of the time. She has lots of articulation issues, particularly with velars and stridents, which she tends to delete or stop. She's very loud, and she is scheduled to be seen by an ENT very soon. But her language was fine, let me tell you. She had an opinion about everything, and she was not the least bit shy about sharing it with you or offering criticisms or observations about everything from the decor to the comfort of our seating to the lack of variety of children's magazines in the waiting room. She was something. Both of her parents are PhD faculty members in other totally unrelated departments as well. So, what are you thinking is going on with this kiddo? So, what are you thinking? Probably. But why? Could be, but that doesn't explain the mouth breathing, the snoring, the hyponasality, the recurrent strep throat. This kid needs a TNA. She needs her tonsils and her adenoids out. They're a breeding ground for infection. They're blocking her airway. If we can, and then because she's breathing through her mouth, she's not getting any kind of moisturization that our nasal passages should provide. So she's drying out. It's becoming a horrible, inflamed breeding ground. At least that's what I'm thinking going into. I'm like, well, ear infections before she was 2. Why the heck are we just now getting here? Well, in talking to the family further, the rationale or the reason was because mom and dad were both in graduate school and they didn't have a lot of money and they were going to school in an area that wasn't real convenient to services, and so pediatrician was the one that was trying to manage it. And you will also find that there are some pediatricians who are very hesitant to refer to specialists, especially when you've got a kid like this, because they're afraid that if they refer to a specialist, they're going to lose that kid because the only time that they ever see the kid is when they've got problems related to ear, nose, and throat issues. And so if I refer to the ENT, then I'm going to lose that patient because they're just going to go the wrong. All right. So that's what her audiogram looked like. She had a conductive loss. It was in the mild range, and it was primarily low frequency. We still had a little bit of an air bump gap when we got up to around 2,000 hertz, but she was essentially normal at that point. Okay? She had SRTs at 25, and she had excellent speech discrimination scores at 100%. Okay? So, what do we do at this point? She had flat tympanograms. So I could not measure acoustic reflexes. And I had OAEs were present, but they were, the noise level was really high, so it was hard to say for sure if they were robust enough to be reliable. You often see that with fluid. They'll either not be there or they'll be there, but you're like, but the noise level is high. So anyway, so what do you think should happen with this kiddo at this point? What were my recommendations? Well, I refer to an ENT, but yes, and that is what happened. And at the same time, while they were in there, they went ahead and placed tubes because they were afraid that. And lo and behold, 2 months later, when she came in for a recheck, post-op, she did not sound nearly as nasal. There was still some there, but it wasn't nearly as bad. I think it was now habit. They're going to have to work on that formally. She was not nearly as loud. She was every bit as opinionated, but she wasn't nearly as loud when she said it. And her hearing levels had returned to normal. There was no longer an ear bone gap.
I have a question about the audiogram. When you look at that, like, how do you determine the severity? Just by looking at it.
You tell me.
Well, I guess
We judge severity by.
by the ear. Okay. So is it the lowest part of the ear, just the worst part, and then that's determined?
So I would say she has a mild reverse slope rising to normal above 2,000 hertz. So she has a mild conductive loss with a rising configuration to normal from 2,000 hertz. I'm sorry? For SRT, you would expect, if you take a pure tone average at 500, 1,000, and 2,000, you would expect the SRT to be somewhere in that range. So if we look, her SRT is 30, 20, and 15. What's 30, 20, and 15? 65, divide that by 3, it's like 22. Okay? And we got it at 25. So that's very close. So what you want is take a pure tone average, and unless there's this huge disparity, like where it's normal, normal, and really bad, but if it's a relatively flat, which this is not terribly sloped, then you should expect an SRT to be probably within 5 to 10 dB of that in one direction or the other. Normally better.
I know this is going way back, but would you judge the severity by, like the worst that she could hear? Or like by that 30 dB? Because that's how you judge it to be contact.
Yeah, I would say she's got a mild conductiveness rising to normal from 2000 hertz and above. But yeah, so you want to go by air. What's the air? Because that's going to determine severity. And then the bone tells you, is it mixed? Is it sensory neural, or is it conductive? So what would it be if, let's say, that her bone conduction scores are down at around 20 dB? Then it wouldn't be conductive, it would be sensory neural.
So why is console something? How do we do that?
Okay, she is not able to make the other sounds, so she can't get her tongue back there. Well, what would be something that would be obstructing her tongue or keeping her tongue forward? The tonsils. Okay? They also account for the constant strep throat that she seems to get. The adenoids and the tonsils together could be preventing the velum from closing, so that could account for the nasality issues. Does it make sense when I explain it?
Yeah, because you just said console, it's not.
Well, think about the back of the mouth. This is a kid where when I said open your mouth, because I was playing around with her with the otoscope, I said, open your mouth, let's speak in your mouth. Well, I didn't even have to shine the otoscope in there, and I could see her tonsils in the back, and they were pitted with, looked like cottage cheese. I mean, she had actual pus pockets. I don't know that it's necessarily that the pediatrician wasn't catching it. I think it was more an issue that the parents were kind of overwhelmed and didn't necessarily always follow through. But now that they were here and they both were gainfully employed and they had insurance and she got what she wanted. But yeah, I sometimes find myself asking, did it take this long? You know, I mean, I'm sorry. I told you about the family where I think the kids have the art. How does the kid get to be 11, 16 years old before they figure out that he's got a hearing loss? Especially when all but one of his younger siblings has been identified with hearing loss. After the first one, wouldn't you say, maybe I ought to get Junior's hearing checked?
Like on my exam, it's like if I was taking them, there is no way that I would have
Yeah.
Then you would have what?
Then I would have been
Well, I wouldn't count off for that, but you would know. Would you have known based on this, ooh, this person needs to see an ENT?
Yes.
Okay, then you would be fine. I would not necessarily. This is not a voice class. This is not, but I would expect you to know that, ooh, there's stuff going on here. This kid needs to see an ENT. Yes.
Do you want to be familiar with distinguishing the types of APUs? So this also means that it's output or
I would suggest that you have an idea about the main characteristics. So I guess the short answer is yes, you should. Okay, let's look at a couple of young adults. By young adults, I mean they are under the age of 55. I'm a young adult. I mean, under the age of 50. Anyway, we have LS. LS is a 50-year-old female. She works in an office at a small business. She does have a family history of hearing loss, but she said it's mostly in people when they get a little bit older. She does say that she's always noticed a problem with her hearing since she was a little kid. She feels that her hearing is interfering with her ability to do her job. She actually quit a previous job that required her to spend a lot of time on the phone and in noise because she just couldn't hear. And she wonders what, if anything, can be done. Her insurance does not cover hearing aids, and she has limited income and limited financial resources. So, what do you think is going on? What should we do?
Well, she's probably already tested.
Yeah, okay? Yeah, let's do that. Okay, so she should definitely have her hearing tested. Yes.
She probably had due to prolonged and was kind of ignored, it probably just worsened even as a result of that.
Okay. So are we thinking this is progressive? Do we think this is stable? Probably slowly progressive. Okay. Are we thinking conductive? Are we thinking mixed? Are we thinking sensory neural? Are we thinking I'm not ready to go out on that limb yet? Okay, to say that, what else do you want to know? I'm glad you asked for it, because there it is. So that is her audiogram. She is showing hearing loss that's in pretty much the moderate range, maybe moderately severe. She has a fairly gentle, kind of upward sloping loss. It is sensory neural. She has good agreement between her SRTs and her pure tones, and she has remarkably good speech discrimination scores when we make things loud enough. She's like above 90%. So it's pretty much normal. So what are we going to do for this lady? What does she need? Okay, so we're thinking assistive technology. Yes, she could benefit maybe from an amplified telephone. But what else? You guys said, I heard hearing aid. I don't know that I'd agree with hearing aid. I think I'd want hearing aids for her. But how do we pay for it? She doesn't have much money. And insurance doesn't cover it. Do what? Well, it would be. So yeah.
Didn't you say that you like put people in a trial experience or something? Was there another half of people or no? Like we're just one. Could it possibly look at the relation for like one?
Vocational rehabilitation. She should be referred for voc rehab services. She has a documented hearing loss. She has limited income and no other resources, and it's actually impacted her employability. She had to leave one job, and she's still struggling in this one. And so we have documentation now that she has hearing loss. So not only will they pay for hearing aids potentially, they may pay for other assistive technology that she might need. They might pay for an amplified phone for her at home and at work. They may pay to have a captioned telephone. They might pay for a streamer that allows her hands-free Bluetooth compatibility with her computer. cell phone if she has one, with her television. So yeah, this is a candidate this is a classic example of someone who should be sent to voc rehab. Because she may not get everything, but we need to start there. If that doesn't pan out, then there are programs that, for example, we are providers for a program called Here Now, which would provide patients who meet the income requirements, and she may not, she may make too much money. But if they meet the income requirements, they will pay for 2 brand new top-of-the-line hearing aids at the cost of $250. Pay $125 per year, which covers their costs for, not for the materials and the components, but for the manufacture of everything. We have to agree to do it, waiving our fees for fitting and everything. So we're basically saying we're going to donate our time, and the company's willing to donate, and that is a possibility as well.
So does that transfer out to the manufacturer then, not like through you guys, like the $125 per year goes straight to the
It
manufacturer?
goes straight to the manufacturer. They have to send a money order or a cashier's check with their application. And we do a screening to check and make sure that they look like, because they tell us what the income requirements are based on their household size. And so if I see they don't meet the income requirements, I'm not gonna have them waste that money. I'm gonna say, look, this was our only hope, but, because I've had people who have very limited income, and on paper, it looks like they make it, but then we find out, oh, well, they have $5,000 put away in a savings account that's their funeral fund. Well, that's all fine and dandy, and that's a great thing, but this foundation is gonna look at that and say they have $5,000 of disposable income, right, so we're not gonna. Okay, all right, so that's LS. Now we have FS, who's 55. He has a history of noise exposure, both occupational and recreational. He has unbearable ringing in his ears. He denies having any hearing loss, but does admit he sometimes has problems understanding on the phone. His wife's frequently complaining that he listens to the TV too loud, and he doesn't always seem to hear her when she's talking to him, but he thinks that's just convenient hearing from being married to the same person for 35 years. Okay. So the problem is not his hearing, it's everything else. So he actually came in for a tinnitus assessment and hearing test. When we did his tinnitus assessment, he was a grade 3, which is moderate, which means that his tinnitus could be debilitating enough to occasionally disrupt sleep and daily activities. His tinnitus handicap score doesn't really match well with his description that it's unbearable. So he's describing it as being, I would have thought that he would have scored like in the catastrophic range. Because he was talking about how it's driving him crazy. He's had, as he put it, bad thoughts. And yet, when he actually filled out an objective questionnaire, it wasn't coming out nearly. So there's some discrepancy there. And his tinnitus roughly corresponds to the range where he has the worst amount of hearing loss. So what do we do at this point? There are hearing aids that are available that are just hearing aids. There are hearing aids that are available that also provide tinnitus masking, so they're a combination. Or you can just do plain tinnitus maskers. This guy has both issues.
Didn't you say a lot of the time if somebody has a hearing loss and fix that, it'll fix the tinnitus as a result?
Up to 80% of the time.
So so you should try this.
So, yes, what I would probably do, first of all, I do a lot of counseling with him in terms of, you know, what's his lifestyle like? Does he have high caffeine intake? Because that can be a trigger. Does he have high salt intake? Because that can be a trigger. Does he eat a lot of processed foods with nitrates and nitrites and MSG and things like that? Those can be triggers for people. What are his medications like? There are some medications that can trigger tinnitus. So we'll look at all those things. But then we would want to try. I typically will try, if they have both hearing loss and tinnitus, and objectively it's not coming out in the horribly catastrophic, the severe catastrophic range, I'm going to try regular hearing aids first because they're significantly less expensive. And let him try it and see if he gets relief. And if he doesn't, we can always exchange them for the ones with tinnitus masters. One of the manufacturers now is really cool. They send you a hearing aid that has a generic chip in it when it comes, and when we hook it up to the computer, we pick what level of technology we want and what special features, and they can try it when they bring it, and we set how long. So after, say we set it for 2 weeks, after 2 weeks, the hearing aid just goes beep, 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 doesn't work. Someone else comes in, they have totally different hearing loss, totally different hearing needs, we reprogram it for them and we reset. So it actually has the option where he could come back in, I could add the tinnitus masker to it, see if that helps, and then he can make that decision. So, but yes, you're absolutely right. So this guy, he needs counseling on tinnitus management, and he needs amplification, possibly tinnitus master. Good job, guys. Okay. That was his audio, by the way. Yes.
That just reminds me, what's the disorder that usually drops down at like 6?
Noise-induced hearing
Yeah,
loss.
like
The not, to
the
have a
knot,
not.
yeah. Is that noise induced?
And he kind of does have a little bit of a nod, because you can kind of see it, especially in the left ear. It doesn't recover, but it kind of stops and
Right.
flattens out. So. All right. So now we're going to talk about a couple of older adults. So this is my problem patient. The one that just will not go away. The one who tries to bribe me with promises of dinner and drinks if I will come to her home and make house calls. She just, it's a hassle for her to get in. She drives me crazy. But it's been 3 months since she's called. And I think the last time when she really did kind of overstep the line, I think a little bit with the offer of dinner and drinks and show you a nice time for the evening. Didn't bother, didn't even go or ask her where she was going with that. Because that's what kind of, I was like, okay, that's, maybe my mind's in the gutter, based on my experience with her. She's always touchy-feely. I was like, sister, we're not going there. And, no, sorry, as a matter of fact, that was, so what just happened, it was right around Valentine's Day, and I was like, you know what, I'm going out to dinner with my wife to celebrate Valentine's Day, so I'm not going to be like home early. And 86, she's a retired music instructor and professional pianist. Ashley, you've met this person, you know who this is, but yes. But anyway, she has a long-standing history of sloping mild to moderate sensory neural hearing loss that was slightly worse in the right ear versus the left ear. But she's been successfully using hearing aids for a number of years and would basically come in for like an annual checkup, and that's about it. Well, 2 years ago, she was in a motor vehicle accident where she was the passenger. They got T-boned, and she sustained multiple fractures of the right side of her face, a right knee injury, and lots of contusions. Since that happened, she's noticed almost immediately a change in hearing in her right ear. And she was describing for me the musical notes, and it corresponds to a mid-frequency hearing loss. So she came in telling me this is where the problem is. So, and she was having a dramatic loss of speech clarity. But she felt it was in both ears. Over the course of several months to a year, she's gotten increasingly frustrated. Both myself and her daughter, since all of this has been happening, we're starting to notice some decline in memory, cognitive function, and she just says, I just want to hear like I used to hear, or at least better than I do now. Okay, so over here is what her hearing had been like prior to everything. Then this is what her hearing is like after the accident. So note that she was right. There was this huge chunk of now missing information in the mid-frequencies. Okay? So, what should we do for something like that? Or at least try and adjust what she has, yeah. So we want to definitely modify, adjust amplification.
She already had him with hearing aids?
Mhm.
As a safe, right?
Yes. She already had hearing aids and had been successful with them, but ever since the accident, she felt like they weren't helping. But she would just call and complain that her hearing aids weren't working well. She would never take us up on an offer for an appointment or to recheck her hearing. Once she finally, that went on for a long time. And she would call and she would say things and we're like, hey, we just talked about this. And then finally her daughter called to us. I don't know if you noticed, but I think my mom's having some cognitive issues. So we finally got her to come in. We found objectively the change in her hearing. We addressed that. She still complains that she can't hear. She can't understand. So what do we do at this point? Obviously, amplification is not enough.
Have you, done a diagnostic test or evaluation she did in hearing aids? To see if it's really as bad as she considers with the hearing aids, or if she's just like exaggerating it?
It's really hard. I mean, it's a perceptual thing. So I do believe, with that she is, she's truly having more problems. So what are we going to do for that?
Put her in some kind of counseling or like group probably have or something so that she can.
Okay, right. And definitely we have to counsel. I mean, she's got very unrealistic expectations. I'm like, look, lady, your hearing has changed. I'm sorry. Musicians, believe me, if you ever have, whether you're a speech pathologist or an audiologist, if you have professional musicians, professional singers, they are going to be run screaming from the room because they know music and sound as well as we do, but from a very different perspective. And so it's often we find ourselves not really communicating. We're talking about the same thing, but on very different pages. So, but in addition to the counseling, trying to get her to realize that her expectations are probably unrealistic. What's a component of oral rehab with adults that probably needs to be addressed with her?
You can do like ear ribbons or whatever the take-home things are.
Lace would be excellent.
Yeah.
Yes. Lace because it's specifically designed for these kind of content. Lace is an excellent idea. She wasn't real keen on that because she just got a computer and she's not even sure she remembers how to turn it on. Those are her words, I swear, I'm not kidding. So I said, well, do you have a DVD player? Well, yeah, but I can never figure out how to work it. Every time I want to work it, she lives at the Knolls. Every time I try and work it, I have to get one of the girls to come over and help me with it. And I said, well, do you think that they would help you? Because there is a DVD version. And so, bottom line, we did recommend Lace for her. I've gone online because I can track it like Big Brother. She's used it twice. And when the last time that she called, and I called her on that, because at that time I used it once, and it's been several weeks, I said, but I see you've only used it once, and I told you this is something that you should do a couple times a week, at least. I think she kind of got the hint that until she makes the effort to do something more, and I'm not being hateful to old people, please don't, I love elderly people. I have spent a great part of my career working with them, but this lady is so unpleasant. Yeah, it's not just that she's needy, I can deal with needy. She's like really sarcastic and condescending in her attitude, and I don't deal with that. But anyway, so I'm not really sure what's going on. She wanted me, we got her new hearing aids. We tried several different styles. We got her hooked up with accessories. All she had to do was, they even had her grandson, who was very tech-savvy, come with her. And he had taken pictures of her TV and the different ports and everything, so that I could actually show them, hey, this piece right here goes in that, and yet she was constantly calling it, well, this isn't working, and that's not working, you need to come out to my apartment. And I'm like, no, I don't need to come to my apartment. So anyway, I did suggest that to her daughter, and I said, are you comfortable? She goes, please don't, because she said then she's going to think that I called you and put you up to that, because I've been trying to get her to go. I said, okay. So I just documented that we have had these conversations, and that the daughter, who is her power of attorney, she did not get that, had said she did not want me to discuss that with her mom. So basically, but yes, I would otherwise, because I do think she has some dementia. And I think she's sundowning where it gets worse as the day goes on. And that's why I certainly don't want to join her for dinner and drinks. Because I could just see it really splash in the headlines that I did something inappropriate. Not one. All right. Let's try this. We have a 90-year-old female. She's a retired secretary. She feels like she's had hearing loss for about 5 years, although that's questionable. It's probably longer. She has a set of older analog hearing aids, so they're not new technologies. She said that she hears better in noisy situations than in quiet, and that her hearing is better. Yes, I know. I see the face. I do the same thing when they tell me that. And she said that she stopped wearing her hearing aids because they keep going dead. And she's interested in what can be done to make her hear better. Okay? So, that's what her hearing looks like. So, what are we doing for her? What would an oral rehab program for this lady look like? Obviously, she needs hearing aids. Probably needs some assistive technology to go along with it. But what's the nitty-gritty? What are the things that I might say to you, my colleague in speech pathology in the clinic? Okay, we can't bill for me wanted to provide oral rehab for her. I really want some oral rehab for her, so I'm referring her to me. What are you gonna do? In like what nature? Would you do it individually? Would you do it in a group? Sorry, I saw that okay face. I'm like, I'm not making myself clear. It's not you, it's me. Yeah, I do think she would be a great candidate for group oral rehab to work on some speech reading training. What else could she then get through that? Some communication assertiveness training. That might be very helpful for her. So yeah, I think she'd be an awesome candidate for group. And maybe some individual. Maybe we need to, there may be some specific things. If we can get significant others, so we can do clear speech training, might be very helpful. Help orient them to her technology as well. I mean, she's pretty much the classic. This would be, the generic, what's the optimum, what's the ideal? Pretty much we did that for her, I think, with that outcome. So that's what was recommended. And at the time they were having, she actually had the opportunity to get follow-up through the VA, because she's a TRICARE widow, and so they actually had some group oral rehab programs at the VA she could go to.
She's not, I don't think she's very delicate, like, I feel like 90's like really old, would there be other people as old as her? I just feel like. it's like-
90's the new 75. Seriously, I mean, it really is.
Would there be other people like her age, like?
Oh, sure, sure.
Or-
And if this were in Florida, she'd be a youngster. We had cochlear implant patients that were 96. I mean, seriously. At the University of Florida, the oldest cochlear implant patient that we had at Shands was 96. So, that's young. Are they sociable? Are they right? And are they participating in any kind of group activities? If they're not, then I'm gonna probably recommend more one-on-one. That's probably more appropriate to the types of communication situations they're gonna be in. But she's still trying. This is funny. This is a quote. I drive my older friends to all of their appointments because they don't drive. And she goes, and you know how some of those old ladies can be. A lot. I swear to you, she said that those old ladies mumble a lot. She's 90. They're old ladies. Okay, so whatever. It's all in your perspective. All right, let's do this last one. We have a 76-year-old female. She's a retired librarian, long-standing history of stable but seriously profound hearing loss that was identified when she was 6. Until recently, she'd been using hearing aids powered behind the ear. Hearing aids, she was even able to use her cell phone without any problem. And let me tell you, people with that type of hearing loss with standard PTs don't do on cell phones, but she was. She had been having a 3-month history of increased difficulty understanding speech, both with and without the hearing aids. And the troubleshooting check her hearing aids indicated that they're working to specifications. Okay, so we're thinking it's not the hearing aids, something's going on with her hearing. So, this is what her hearing had been like, and it had been like that for a long time. Then when we checked her, this is what her hearing had been like. She basically bottoms out in the left ear above 750 hertz. She's got no useful hearing anymore. And she's had a dramatic drop right ear. Her speech dictation went from the 60s down to the 20s and 30s. What are we recommending for this patient? I think I heard it. What did you say, Grace? Yes, we did. She was in her 70s. And she actually opted to go through with it and is actually doing quite well. Question?
If they decide not to get it, what happens?
You tell me, what would you do then? That's a very good question. And that would be something that would not be at all unlikely to put on the exam. This is what we recommended, and she chose not to do it. So now what are you going to do with her? Okay. Primary problem is she's not understanding. So what can we do to address that? Speech reading, excellent. Maybe cute speech, yeah, that's good. What else? Tom? What did I recommend for my lady, my girlfriend? Mace might work. That might be very helpful. You might look at additional assistive technology, maybe we get her a caption telephone. You guys have all seen that commercial, right? You're about the grandma, grandma, you know, the caption phones are great, and those are available for free or at a very low cost to folks. So that's definitely something to look into. So yeah, but we're gonna have to drop to Plan B then and do a more traditional approach. And there's nothing wrong with that. But thankfully she did agree and was determined, as we figured she would be, because we kind of know what the criteria are going to be, that she was considered to be a good candidate. She did not go for bilateral, which I'm not surprised. She did go for implantation in her left ear, and she still has some quasi-useful hearing in the right ear. She's doing quite well. Yes.
I just forgot my question.
Okay.
Does she still use a hearing aid for the other ear?
It's bizarre, and it's not what I would do, but I have a number of patients who are doing that, where they continue to use a hearing aid on their better ear, and they have the implant on the other ear, and they learn, to me, I'm like, talk about auditory integration difficulties, but, she does, and she's one of several that I have, and she's doing quite well. Yes?
The vocational rehab, is that not with your insurance benefits? Is that what
Voc Rehab is, their main thing is there an impediment to your employability, educational, but it's all related to vocation, so, and then they look at what are your resources. So if you have insurance, but it's not gonna cover anything, then they're gonna potentially kick in, it's also related to
they
income.
will still hopefully you don't have to.
Right, yeah. But the beautiful thing is, especially for the elderly, Medicare pays for it. Medicare pays for our rehab for elderly. So, okay, questions? So, this is the kind of stuff that I'm going to give you on the exam, where you're going to have to describe and talk about from the audiogram. You're going to have to label and describe the type, configuration, severity of hearing loss. I might give you not only the audiogram, but some background history, and you have to come up with a plan, an oral rehab plan for that person. If it's a kiddo, I might ask you to, okay, now describe to me what's the process to get this kid into early intervention, and once they're at that point, what would be the process of getting them into services in the school system? Okay? So that you can show me you know how to help a patient navigate through that system, for example. I might give you a scenario where a researcher's considering a specific clinical question, and they're considering a number of different research designs for their project, and I would want you to tell me the one that you think would be best at providing valid, repeatable, generalizable results based on the possibilities of how we would design it. So I'm not going to ask you to tell me what level of research evidence this provides, but at least know which one would probably give you a better result. Those kind of things. Troubleshooting hearing aids. I'll give you some descriptions and you tell me how you would go about what you would do